Welcome, future nurses. Okay, let's just dive right into this explainer. Look, if you're gearing up for the NCLEX, you're probably feeling, well, completely overwhelmed by this giant mountain of facts, diseases, and meds that you think you need to memorize. But let's just take a breath. I want to totally reframe how you look at this exam. The NCLEX? It is not a massive memorization test. Actually, it's a straightforward safety test. That's it. So today we're opening up our NCLEX Playbook to help you shift your mindset so you can start thinking exactly like a safe, entry-level nurse. Here is our game plan for today. First, we are decoding the NCLEX exam. Second, we'll master prioritization strategies. Third, we'll hit those high-yield clinical alerts. Fourth, we'll go over the rules of delegation. And finally, we will wrap up with your ethical and legal duties. All right, Section 1, decoding the NCLEX exam, understanding the game. To beat the test, you first have to understand what the computer algorithm behind it is actually trying to measure. And here is the big secret. Its single purpose is public protection. Seriously, this exam is not trying to trick you. It really doesn't care if you can recite a textbook word for word. It literally just wants to verify one single thing. If we hand you a nursing license today, will you accidentally harm a patient? Every single question is just the computer evaluating your clinical judgment to see if you can safely protect the public. So how exactly do they test that judgment? They use the clinical judgment measurement model. You are going to be constantly asked to step through 6 specific layers. First, recognizing cues. Basically, can you spot abnormal or worsening findings? Next, analyzing those cues to figure out the pattern. Then prioritizing hypotheses to pinpoint the most dangerous threat. After that, generating solutions, taking action by picking the safest intervention first, and finally, evaluating the outcomes to see if your patient actually got better. If you can walk through those steps, you are going to pass. Moving right along to Section 2, mastering prioritization strategies. This is the ultimate strategy because you're going to be faced with scenarios where, honestly, every single patient seems incredibly sick, and you have to decide who gets your attention first. Assuming you don't have an immediate airway, breathing, or circulation emergency right in front of you, you can cut through all the confusion with these golden rules. Number 1, acute always beats chronic. A brand new, severe problem absolutely requires your attention before a stable, long-standing one. Number 2, unstable always beats stable. A patient with abnormal vitals or maybe a rapidly declining level of consciousness, that is always your priority over a predictable patient no matter what their underlying diagnosis is. Okay, let's test that logic real quick. Which finding do you think is the priority here? A patient with emphysema presenting with crackles in their lungs, or a patient with a respiratory rate of 8? Think about it. Both involve the respiratory system. Both sound pretty bad, right? So who do you see first? The trick here is understanding expected versus unexpected findings. Emphysema with crackles? That's an expected finding for them. It's just their chronic baseline. But a respiratory rate of 8? Now that is a totally unexpected finding. Normal is 12 to 20. A rate of 8 signals severe respiratory decompensation, maybe from an opioid overdose, who knows? The point is, unexpected complications always outrank normal chronic disease symptoms. You run to the patient with a rate of 8 immediately. But listen, beware. There is one ultimate trump card you will see on the exam, and that is stridor. Stridor is this harsh, high-pitched inspiratory sound, and what it means is that the upper airway is actively closing. This outranks absolutely everything else. It is a drop everything, immediate airway emergency. You stay right there with the client and you prepare for intubation. No exceptions. Section 3, high-yield clinical alerts, the critical numbers. Let's take some of those absolute must-know clinical data points and translate them into super easy-to-remember rules of thumb. If you ever see a mean arterial pressure, a MAP, under 65 millimeters of mercury, alarm bells should literally be ringing in your head. Your patient's organs are starving. They need consistent blood flow to survive. And a MAP under 65 means entirely inadequate organ perfusion. That patient is at immediate risk for acute kidney injury, altered mental status, and severe tissue hypoxia. You've got to report this right away. Now, for head injuries, you need to burn the mnemonic WBI into your brain for Cushing's triad. That's widened pulse pressure, bradycardia, and irregular respirations. If your patient has a rising systolic pressure, a dropping heart rate, and irregular breathing, this is a massive, massive neurological emergency. It tells you there is dangerously increased intracranial pressure. Do not wait around. Notify the provider immediately and get ready for emergent interventions. Oh, and here is a fast, incredibly useful rule of thumb for blood pressure measurements, because test makers love to ask about this. Just remember the simple alliteration: large equals low, small equals high. If you try to squeeze a tiny pediatric cuff onto a bodybuilder, you're going to get a falsely high reading. If you use a cuff that's way too large, you get a falsely low reading. It really is that simple. So, what about IV fluids? This trips people up a lot. Just think about where the water is going. For hypotonic fluids, think hippo. Water rushes into the cell and it swells up big like a hippo. For hypertonic fluids, think hypershrink. Water is pulled out of the cell, shrinking it down. And for isotonic fluids, think isostay. The fluid stays exactly where you put it, right inside the blood vessels to just expand volume. If you just visualize those cells swelling or shrinking, you'll nail the correct fluid choice every time. Let's jump to Section 4, Rules of Delegation and Team Dynamics. Navigating team dynamics and handling delegation is a huge part of management of care on the exam. Here is the absolute core concept you have to grasp. Delegation is transferring responsibility for a task while the registered nurse retains absolute accountability for the outcome. Put simply, you can hand off the physical work, sure, but you can never, ever hand off the accountability. If a delegated task goes sideways, the RN is the one left answering for the patient's result. So, how do we divide that work legally and safely? Well, the registered nurse takes the unstable clients, does all the initial assessments, and handles the complex teaching. The licensed practical nurse, or LPN, they take the stable clients, administer routine medications, and they can reinforce teaching that the RN has already started. Finally, the unlicensed assistive personnel handles those standardized, super predictable tasks, things like hygiene, ambulation, and grabbing routine vitals. But to protect patient safety, there are some really hard, non-negotiable boundaries here. You can never delegate unstable clients whose conditions are actively changing. You cannot delegate initial assessments that require your clinical judgment. You cannot delegate brand new client and family teaching, and you absolutely cannot delegate the evaluation of care to see if a treatment actually worked. The RN has to retain those duties every single time. No shortcuts. All right, Section 5, Ethical and Legal Duties, the Rule Book. These are the tricky legal frameworks and ethical traps that catch a lot of well-prepared test takers completely off guard. Let's start with a classic clinical judgment scenario. As a nurse, you're carrying out written prescription orders, right? But you act as the ultimate safety net for the patient. So when do you question an order versus clarify an order? They might sound interchangeable, but legally speaking, they are two very, very distinct professional duties. You question an order when you believe it is actually unsafe, harmful, or contraindicated, like if a provider orders a med that the patient has a known severe allergy to. You question it. You are stepping in as their safety advocate. You clarify an order when it's simply vague or missing a piece of information. Say an insulin order just reads 10 units now, but doesn't say if it's sub-Q or IV. It's just incomplete. You aren't challenging the safety of the drug itself. You are literally just calling to fix a missing detail. Another huge legal trap is informed consent, and the lines here are incredibly firm. The provider's job is to obtain and administer the consent. They are the ones who have to explain the risks, the benefits, the alternatives, and field any medical questions. As the nurse, your job is purely to act as a witness. You confirm the patient is who they say they are, you make sure they're competent and not heavily sedated, and you validate that they're signing it voluntarily. If the patient says, "Wait, what exactly are they cutting?" you stop right there and you call the provider back. You also have really strict legal duties when it comes to mandatory reporting. You don't get a choice in these matters. State law demands it. You must report any suspected abuse of vulnerable populations, so children and the elderly. You absolutely must report impaired healthcare workers to your nursing administration immediately. You're also required to report clients who threaten self-harm, specific communicable diseases for public health tracing, and criminal injuries like gunshot or stab wounds. Following these rules isn't just best practice. It protects the public, and it protects your license. So that brings us to one final thought. Remember, the NCLEX is not some big enemy trying to keep you out of the profession. It's really just a gatekeeper, and its only job is ensuring that when you walk into a patient's room on day one, you are fully equipped to keep them safe. Trust the safety priorities we've discussed today. Take a deep breath and ask yourself, are you ready to protect your patients and your license? I know you are. Thank you so much for joining me on this explainer, and best of luck on your exam. You've got this.